Hello, my name is Dr. Asher Kaufman, and I'm a member of the Division of Neurosurgery at Michigan State University under primary investigator Dr. Tex Su. Today I will be presenting multi-level stabilization screws, prevent proximal junctional failure and kyphosis in adult spinal deformity surgery, a comparative cohort study. As the global population continues to live longer, the incidence of adult spinal deformity is increasing worldwide. For complex ASD, open surgery with thoracolumbar fusion remains the standard of care. Spinal deformity surgery retains a high morbidity rate, with 70% of patients experiencing at least one perioperative complication and 28% of patients requiring reoperation. Two common complications are proximal junctional kyphosis and the more severe proximal junctional failure, which develop in 20 to 40% and 5.6 to 38.5% of cases, respectively. PJK is a radiographic finding defined by a 10-degree or greater increase in kyphosis from initial postoperative films. Kyphosis is measured from the superior end plate of the upper instrumented vertebra of the construct's cranial aspect to the superior end plate of the level 2 vertebral bodies above. PJF was more recently codified by the International Spine Study Group as the development of any of the four distinct postoperative criteria: an increase of 15 degrees of kyphosis, fracture of the UIV or UIV plus 1, failure of UIV fixation, or need for proximal extension of fusion. Current research and prevention of PJK and PJF in ASD surgery is focused on the augmentation of cranial aspect of the construct. A novel technique proposed by the primary investigator is the use of multi-level stabilization screws at the top of the construct. Under fluoroscopic guidance, the cranial-most screws are directed through the pedicle in an inferolateral to superior-medial trajectory, thus avoiding the neural tissues and traversing as many vertebral levels as possible. The remaining caudal levels are instrumented in standard fashion. Here you see an anterior, posterior, and lateral intraop fluoroscopic X-ray of the spine. These red circles demarcate the pedicles as seen on the AP X-ray. The pedicle probe can be seen entering the superior pedicle with an inferolateral to superior-medial trajectory. The limits of the pedicle are delineated by yellow on the lateral X-ray. The pedicle probe is seen safely traversing the pedicle. Once safely through the pedicle, the probe is advanced deeper through the vertebral body towards the superior end plate. The probe is now passed superior to the initial vertebral body, extending an additional 2 vertebral levels as seen on this lateral. Here, we demonstrate final postoperative CT reconstructions of the construct. Our population was a single institution consecutive series from 2009 to 2017. All adult patients who underwent open, long construct thoracolumbar fusion for ASD with a minimum of 1 year follow-up met eligible criteria. All constructs extended greater than 3 levels, with cranial aspect higher than T6 and caudal aspect lower than T12. Our intervention was comparing MLSS versus standard long construct thoracolumbar fusion technique. Our design was an observational longitudinal comparative cohort study. Our primary outcomes were PJK and PJF as determined by 2 independent evaluators with a 3rd arbitrator. We also looked at surgical complications. For statistical analysis, comparability was evaluated using univariate analysis. Covariates were adjusted for using multivariate regression models for PJK and PJF. Sensitivity analysis was used to account for patients lost to follow-up. Patient demographics, perioperative data were also collected and adjusted as covariates. Here we see patient demographics and surgical characteristics. The control arm of our study had 26 patients, while the experimental MLSS arm had 50 patients. The only significant difference between the 2 arms was that the MLSS patients were significantly older. While the MLSS patients' constructs were significantly longer, this is partially due to the nature of MLSS. Otherwise, there were no significant differences in surgical characteristics or complication rates. Here we demonstrate the primary outcomes of our study: PJK and PJF. In the control arm, the incidence of PJF was 30.8%, while it was only 10% in the MLSS experimental arm. This was significant with a p-value of 0.23. Acute PJF occurred in 15.4% of the control arm, while occurring in only 0% of the experimental MLSS arm, with a p-value of 0.004. Approximately 5.2 degrees of kyphosis developed in the control arm versus 1.3 degrees of kyphosis in the experimental MLSS arm, for a p-value of 0.014. Here we demonstrate the multivariable analysis of proximal junctional failure and kyphosis in our study. Using the Bonferroni correction, a p-value of less than 0.008 was considered significant. And when controlling for other covariates, the presence of MLSS was the only independent variable significantly associated with decreased PJK. MLSS was associated with significantly lowered incidence of PJF with a greater benefit in acute PJF. MLSS was independently associated with a significantly decreased degree of postoperative kyphosis. MLSS was not associated with increased perioperative or postoperative complications. MLSS is both safe and efficacious in the prevention of PJK and PJF. It should be considered part of the neurosurgeon's armamentarium when approaching ASD.